I would like to invite our first speaker in the afternoon session, Dr. Donald Stone, to talk about the keratoconus. Dr. Stone is the Director of Research Department at King Khalid Eye Specialist Hospital. He's a senior consultant, a member of the anterior segment division. Please, Dr. Stone.
Good afternoon, everyone. I like being a little earlier in the afternoon so that you haven't had time to fall asleep from that wonderful lunch that we just had. So hopefully I can get through some of the information before everyone falls asleep, me included. The difficulty in a presentation like this is that the audience is very diverse. There are people in this room that have been doing this for a long time. I'm not saying anyone here is old, but I'm saying there are people that have been doing this for a long time and really know a lot about this topic. And there are some people that are perhaps just beginning their career in eye care, and perhaps all of this is completely new. And so I'm going to try to offer a little bit of something for everyone. So for those of you just starting out, this will hopefully be a good introduction to keratoconus. And for those of you that have been doing this a long time, I'll try to put in a few things that are state of the art and provide a little more insight into where we are and hopefully where we're going with keratoconus. So thanks again for the invitation, and appreciate being here. So my disclosure, I have no relevant financial interest in really anything, and most of the things I'm talking about will be off-label. So use at your own risk. The reason to educate ourselves is because we only see what we look for, and we look for only what we know. In other words, you can see something over and over, and if you aren't looking for it, you might miss it. And the reason why keratoconus is important is for two things. One is it is a very common cause of visual dysfunction in the Arabian Peninsula. And so a lot of your patients will have this condition, and the more educated you are, the better care you can provide. The second reason is that it's also a risk factor for post-LASIK ectasia. And so if you are in a clinic where patients are seeking refractive surgery or even just asking you about it, it's good to be educated about this condition. So keratoconus is not only common, I'll say it's an epidemic in the Arabian Peninsula. And so really a critically important issue. It's the most common corneal ectasia of all of this category, and it comes from one of those simple words, keras meaning cornea and konos meaning cone. It's not a very imaginative name, but it describes it very well, a cone-shaped cornea. And that describes what we find clinically, which is this progressive thinning and anterior bulging of the cornea. And this is one of those times where I'll admit that English is a terrible language. I'm glad that I learned it first, because learning it second, I can't imagine. It makes no sense most of the time. So thinning, meaning sort of active, progressively getting worse. So you'll find a lot of thin corneas, but thinning implies action or progression. And that's the key difference here. Sometimes we don't know. We'll examine a patient for the initial visit, and they might have a thin cornea. And if everything else looks normal, we don't know if they have a thin cornea or a thinning cornea that's going to progressively get worse with time. So that's one of those instances where we have to take the advice of don't just do something, stand there. You wait. You see them back in a few months. You see if it's getting worse. And time will tell if this is progressive or not. The prevalence, depending on what population you study and where you study it, varies from anywhere from 1 in 1,000 to some European and North American populations to 3 or even 7 or 10% in some populations from Southeast Asia into the Arabian Peninsula. So there's not a lot of good epidemiologic data, but enough to tell us that this is a very common condition. And worryingly, it's actually more common among those patients who are seeking LASIK. And you think about that for a moment, that's a disturbing thought. But the patients with keratoconus tend to be progressively myopic. They tend to have poor quality of vision. And so these are the very people that think, you know what, I want to get my eyes fixed. I'm not happy with my vision. I'm going to get them fixed. So they find whoever advertises laser vision correction. And so unfortunately, you actually have a selection bias among patients seeking refractive surgery for more keratoconus patients. So another reason to be very careful. It's typically a bilateral disease. I put a question mark there because sometimes it can be very asymmetric, but typically a bilateral disease. It's associated with eye rubbing and also in patients with trisomy 21 or Down syndrome. And associated with this rubbing mechanism, atopy, so patients that have allergies, a lot of eye rubbing, vernal keratoconjunctivitis, obviously VKC is also very common in this region, so this is a common coincident feature. Typically, the onset is in the second decade of life. You will occasionally see it in patients that are 8, 9, 10 years old, but typically it's a teenager is when we first make the diagnosis, and typically stabilizes by the 4th decade. So this is one of those few things that gets better as you get older, unlike almost everything else. And it's actually interesting that this mechanism is a little bit of foreshadowing in one of our treatments, cross-linking. One of the things that you learn in medical school is that systolic blood pressure tends to go up as you get older. Even if you're healthy and eat a good diet, the connective tissue around the aorta and the large blood vessels flexes and stretches. So every time the heart pumps, it gushes out this bolus of fluid, the vessels stretch, and then the valves close, and those vessels contract and squirt the blood further along. As you get older, that becomes more stiff and doesn't stretch, so the blood pressure goes up every time the heart pumps. That's systolic hypertension. And that's because of collagen cross-linking. The natural collagen develops non-enzymatic cross-links, so it becomes stiffer and interconnected in ways that aren't broken down by the normal enzymes that regulate and remodel the collagen, and so it becomes stiffer, less elastic. And for your blood vessels, that's bad. And for your joints and everything else that gets stiffer as you get older. However, for the cornea, it's actually a good thing. And that's why in most people, keratoconus tends to stabilize into their 30s and 40s, because this non-enzymatic collagen cross-linking makes the collagen stiffer. How do you diagnose keratoconus? Well, today, topography and tomography are the gold standards. And we'll spend a little bit of time talking about what these tests are and what you look for and how we use them. There are other signs that you can use, and especially working as a technician, if you're not in an anterior segment or refractive surgery clinic, you might not be getting topography or tomography on every patient. In fact, you might rarely get it. But you will still see patients with keratoconus. When you think about those incidence data that we saw earlier, if 5 or 7% of your patients have keratoconus, that means that almost every day you should almost incidentally pick up a case of keratoconus if you're looking for it. And today we're going to learn what to look for. So look for scissoring of the red reflex if you're doing retinoscopy. I know the people these days have their autorefractors, but there's this great, wonderful instrument called a retinoscope. It's the original wave scan, and really gives you a lot of data. Some people probably don't even know where theirs is and how to turn it on, but they're really useful if you want to learn how to use that. Sometimes on the red reflex you can see an oil droplet, and it's not the typical oil droplet cataract you can get in some metabolic conditions, but the cone, if it's a little more advanced, can give you this central globule looking retinoscope reflex. And once you see that, then you'll say, aha, I don't need topography, I know this is keratoconus. If you're doing pachymetry, you might see central thinning. Often on refraction, you will see progressive myopic astigmatism. This is typically the first warning sign, is that the patient comes in and over their teenage and early 20s, they've gone from being a low myope to having progressive myopic astigmatism, and then their quality of vision begins to drop, and then you can't correct them to 20/20 anymore. And that's typically when they're sent for evaluation and the diagnosis of keratoconus is made. So this is a red flag. When you see progressive myopic astigmatism, always think about keratoconus. And if on your retinoscopy or topography or anything else the astigmatism is irregular, think about keratoconus. This is one of those cases that when you go to a meeting, people always show the very extreme cases that are obvious. You know, it's not the mild ones that you really face in clinic, but this is a more extreme case just to highlight what you typically see. And you can see as this patient is looking down, this is the Munson sign, so the cone is actually pushing the eyelid down in a V. You don't need topography to make this diagnosis. You can also see, let me see if my mouse works here. You can also see an apical scar. I guess you can't see my mouse. My pointer isn't bright enough. Anyway, right up there, you can see an apical scar, that gray area just above the lid margin, and that's in severe keratoconus. You can develop this scarring at the apex. I used to think that you only saw that if the gas permeable lens was fit flat and you had writing instead of vaulting over the cone. But in severe cases, you can develop apical scarring even if they've never worn contact lenses. But often it is due to contact lens fitting with a flat-fitting gas permeable contact lens. If you've seen pictures of the iron line, it's better seen with the blue light. This is actually what it looks like on histopathology. So this is a cross-section of the cornea. The front of the cornea is up on the top, and then the bottom is down, that's the posterior aspect of the cornea. So the more pink layer, that's the epithelium or the skin on the surface of the cornea. And you'll see that blue patch in the middle. That's a stain for iron. And that actually highlights the iron deposition that you see in keratoconus. And it doesn't have to be a complete ring. And there's really not a lot of prognostic data that gives you, but it's one of those moments where you see it and you say, aha, I'm glad that I'm making the right diagnosis. I see a Fleischer ring. But you also may see that on tests or hear about it in other places. So let's talk about topography. It's a term that actually is not just a medical term. Topography just means a way of mapping things out by elevation. So this is just a topographical map, and you can see all the little lines here highlighting hills and valleys. And that actually is a great way to think about the old Placido disc topographers. This is a topographical map. Over on your right, you see some flat plains by this river. And you'll notice these lines. Each of the lines is a certain elevation. And so if you go from one line to the next, if you imagine walking along that plain, it's a long time before you reach the next higher elevation. So it's a very slow, flat slope. So this is very flat. As you get closer to this mountain, notice the elevation lines start getting closer together. So you don't have to walk very far to make a pretty dramatic increase in elevation. And so the closer the lines are together, the steeper it is. So that concept is how you can look at a topographical map and know if you want to take the easy way around or walk up the mountain on the steep route. It's also how you look at topography of the cornea. The cornea on your left, you see all these little rings. These are actually reflected from a light source onto the cornea, and then a camera in the middle of that takes a picture. And you can measure the distance between these rings, just like we did on our topographical map, and it can give you an idea of the rate of change of elevation, so how steep or flat it is. You'll notice the cornea on your right. Notice that the same number of rings are compressed into the center of the cornea. It's because it's much steeper. It's like that mountain that we saw on the last slide. All those elevation lines happen over a very short period of time. So the one on the right is a very steep cornea. The mires or rings are all very close together. So that tells you this is a steep cornea. Now, there was a time where this was all we had for keratoscopy. We would look with these rings and we would subjectively look at it and say, well, this looks a little irregular and here's the axis. But now we have computers to do that for us. So the computer actually measures the distance between each mire and calculates the curvature or elevation based on that, and then generates a color map because we like to look at patterns. And so in this map, it's assigning a color based on the steepness. So red means close to 60 diopters, which is fairly steep. And then blue means flat, down around 41 diopters. So you can see this is a paracentral cone. And this is just the computer putting color on those keratoscopy mires that we saw in the previous slide. So this is all interior surface Placido disc topography. Tomography is something that gives us a lot of the same data, and we sometimes use the word interchangeably. You might hear someone say, I want a topography, but they're really ordering one of the newer machines like the Pinta Cam or Orb scan, which are actually tomography. One of the terms we also hear a lot is a CAT scan or CT scan. That's computed axial tomography. So a tomography means you take cross sections of something and then using a computer program, put those cross sections back together to create a 3D model. And that's essentially what the tomographers do, is instead of mapping the surface with rings like the topographers do, it takes a slit beam, just like you do with the slit lamp in the microscope, it takes a slit beam and then measures the thickness of that slit beam and tells you the relative curvature and thickness of the cornea at each point where it takes an image. The Orb scan takes one slit and slides it across the cornea, taking images as it goes across, and then manufactures a 3D reconstruction of that. The Pinta Cam and Galilei devices utilize rotating Scheimpflug imaging, so it's still a slit beam, but instead of one going across, it's spinning around. So really the same idea, but just different technology. And there may be others out there now. There are new technology coming out every day. But they both take cross-sectional images of the cornea, and they measure the thickness, and they also calculate the curvature and the shape indices. So this is an example of an Orb scan, and it's meant to be blurry because the numbers aren't important at this point. And also the only picture I had of this was a blurry one. But you can see that it gives you a couple of different things. One is on the bottom left, there's a topography. So again, it's not an actual measured topography, it's an estimated or calculated topography. In my experience with the Orb scan, the topography is not great. I typically don't look at that. But it does give you elevation data, and it gives you, in the bottom right, pachymetry, so it tells you the thickness of the cornea. You can see it's thinner in the central, which is normal. And on the top, it gives you something called posterior float. And this is a word you'll hear a lot. What it really means is that when we measure the front of the cornea, most corneas have a very similar curvature on the back. There's a relationship of how they tend to go if they're normal. However, with keratoconus, it tends to start bulging posteriorly first. So as it gets thinner, the anterior curvature doesn't change at first. The posterior curvature changes as you have this thinning, and that's where the change in curvature happens. And so this posterior float is usually the first sign of ectasia, so probably the most sensitive and first sign of ectasia. In fact, in some cases, the topography will be normal in mild or form frust cases, and the posterior float will be abnormal. So this is a little better quality scan. You can see in the bottom right, the central pachymetry is 412 microns, so that's well below normal in any population. And when you look at the top right-hand corner, that's the posterior float. See the red stop sign there? They used red on purpose because if you're wanting to do refractive surgery, this red stop sign says stop. Don't do it. So this is telling you that based on normative databases that the posterior float is abnormal and this patient's at risk for having keratoconus. And therefore, we think risk for having post-LASIK ectasia. And you'll notice that the topography on the bottom left, from across the room doesn't look that bad. A lot of that can be to the color scale, but don't trust just the topography. You really want to look at the posterior float in these cases. This is the Pinta Cam, which again is the same tomography slit beam technology, but just calculates it a little bit differently. And people have their preferences one versus the other. I'm not paid by either company, so I won't give you a recommendation for either one. It gives you a lot of the same data, though. You still have front curvature. In the bottom left, you have pachymetry or thickness. Top right is your front elevation. Bottom right is your posterior elevation. And again, that's your most sensitive area to find signs of ectasia. And you can see a little red spot there where this patient has a little bit of anterior bulging. There's much more you can do with this. When you think about all the data that is gathered when it scans the cornea, we don't want to just look at the same things that the topographer could show us and just look at pachymetry. We had that before. There's some newer calculations that the software upgrades can now perform that can be very helpful. There's an advanced analysis called the Berlin-Ambrosio Index. And what this is taking advantage of the fact that for a certain cornea, we know it's thinner in the central and it gets thicker as you go towards the periphery, but there's a usual proportion that by studying many normal populations, you found what it should be. And so a patient that has a thin versus a thinning cornea, again trying to define that difference, a thin cornea will usually be proportionally thin all the way across, whereas a thinning cornea tends to be progressively getting thinner in the center, and that proportion is lost. And so all these fancy graphs are basically just summing up that proportion. And there's sort of a growth curve in the bottom right, and so you can see if you look at the one, again I wish I had a pointer here, not the bottom graph but the next one up, you see the numbers 400, 600, 800. That's the central thickness. And then as you go peripherally, the thickness should follow that curve. So if you start at 400 or 600, you can predict what the peripheral thickness should be. If your patient falls off that curve, if it gets thicker in the periphery, that means the center is thinner than it should be. And that's actually a very sensitive indicator of keratoconus. An interesting thing about this data is that the studies were very well done. They looked at normal versus keratoconus patients, and they have excellent statistics showing that this really is good at picking out keratoconus patients. What we don't know is that next step, which is, does this predict who would have post-LASIK ectasia? Because that's a different question, and we actually haven't completed that step yet. This is the best data we have, so we use this sensitive scan for keratoconus to weed out those patients that shouldn't have refractive surgery, but we haven't quite made that connection between patients having abnormal scans and having ectasia because no one wants to try it. No one wants to take that risk and treat a bunch of these patients and see what happens. At least hopefully no one is doing that. You can classify keratoconus, and I put this up there, not that anyone wants to memorize this, but basically everything in medicine we like to categorize as mild, severe, small, medium, large. There are many classifications. You see the mildest one here, stage 1, there's eccentric steepenings, that means the topography. You get some myopia, astigmatism, central K readings less than 48. There's actually a category before this, and these are your typical refractive surgery patients where they don't have that much myopia and astigmatism yet. Their corneas are not that thin, and sometimes they'll even have normal anterior topography still, but you find an abnormal posterior float. And those are what I like to call the form-frust keratoconus, meaning they probably have the disease, but they haven't completely manifested it. So they're more keratoconus risk or form-frust keratoconus. Others categorize these diseases a little bit differently. Unless you're doing a research study, it's probably not important to categorize them exactly the same way. We group these in with the other ectasias, and I'll at least mention them today so that you don't leave without having at least heard some of these names. Pellucid marginal degeneration, and we'll show some photos of that in a moment. Keratoglobus is a thinning disorder, but tends to have thinning all the way out to the limbus. Instead of just central thinning, the entire cornea is thin. And it's also steep, and sometimes there's peripheral scarring. And sometimes this is associated with a collagen disorder, Ehlers-Danlos syndrome. Sometimes they can have blue sclera. These patients are actually at risk for spontaneous rupture with just mild trauma. Their corneas are so thin and brittle. You can also have post-LASIK ectasia, and what we don't know is, do you have to have the genes or other risk factors for keratoconus to have post-LASIK ectasia, or is it all related to the treatment? It's probably both. It probably is a combination of you having some predisposition with a certain amount of tissue disruption with the laser, and when you add them up in an equal sum quotient, that's when you get post-LASIK ectasia. And we'll talk about that a little bit more later. So this is pellucid marginal degeneration. You can see in the slit lamp photo on your left, as the slit beam goes down towards the bottom of the cornea, it gets very thin. There's a little bit of scarring there, a little opacity. So pellucid marginal is like a very far inferior peripheral keratoconus. There's probably some overlap in these two conditions, but we like to separate them based on their appearance. When you look at the topography, it shows you what you would expect. Inferiorly, you have this area of thinning, much more inferior than you do in your typical keratoconus patient. And an interesting thing to notice is that actually the astigmatism centrally can be fairly regular. So often these patients with spectacles will still be 20/25 or 20/30 or something like that, and not bad. And you see the topography and say, wow, you have bad disease. And they say, but I'm 20/25, why are you getting excited? And so this sagging bow tie or crab claw is the very typical topography for pellucid marginal degeneration. You can also see post-LASIK ectasia. And so when you look at the central aspect of this topography, you'll see it's blue or flat. So this patient had some type of procedure to flatten the central cornea. That could be RK, PRK, LASIK. Anything that causes flattening is what we do for myopia, because you want to move the focal point closer to the retina. But in this patient, however, you can see peripheral steepening. So the ring of red, you can see where this is bulging and thinning. And so this patient's developing progressive myopia. And over time, this will become worse and worse, and the central area will become more distorted as the disease progresses.
2 minutes left.
2 minutes? All right, very good. So what causes keratoconus? The short answer is I don't know, but because I'm supposed to tell you something, it's probably multifactorial. There are definitely some families that seem to have genetic predisposition, and then I say, to be kind, environmental and behavioral interaction, it's probably eye rubbing. I think eye rubbing is one of the major causes of keratoconus. There has to be some predisposition probably, but it is so often eye rubbing. And in fact, I have seen patients with post-LASIK ectasia that if you tell them to stop rubbing their eyes, it stops progressing. And so it's very important. How do we treat it? Well, first you stop the progression, tell them to stop rubbing their eyes, give them antihistamine drops, try to help alleviate that. Corneal collagen cross-linking, again, that normal age-related process, we copy that. And then we'll talk about improving the vision. We're going to skip over that. There are a lot of different options, and those could be another seminar in itself. Corneal cross-linking was first reported in 2003. It combines UV and riboflavin to induce the strengthening of the collagen fibers, and reduces the risk of progression of keratoconus. Some require retreatment, and I want to show some pictures since you don't really care about the procedure so much. So this is the yellow UV light being applied. So no sunscreen, no hat. This is UV right on the cornea after applying the riboflavin, which is glowing yellow. And this is a treated and untreated cornea. So you can see the one on the right is sort of drooping. It's thin, stretches. The one on the top, you can tell it's yellow from the riboflavin. We can see it's stiff. And so that's the effect of the cross-linking. We don't have any long-term follow-up data on what happens if you take a mild keratoconus patient and do PRK and cross-linking. There are some early reports that show good results, but we don't have 5-year data, 10-year data to know if it's safe in the long term. So at least in these patients, you need to consider a more detailed informed consent. You need to let them know they're not the normal PRK patient, that they might be at higher risk if you're doing this combined procedure. Intracorneal rings can be used to flatten the central cornea, and there are different brands out there. And then I think probably the last thing I'd want to spend just a moment on is the patients will ask, why not just fix it? my brother, my cousin had keratoplasty and they see well now. I'm tired of these contacts. Why don't we just fix it? You know, doctor, why are you holding out on a keratoplasty? Well, because there's a risk of vision loss. Just because their cousin did well doesn't mean that they will do well. Most patients do well. The success rate is 90%, if not higher, for keratoconus patients. But that means that 5 or 10% don't do well. And you never know which patient will be that 5 or 10%. And you don't want to take somebody who's 20, 40 in spectacles and doing well and then submit them to that risk of being that 5 or 10%, having a complication and being worse off afterwards. So you have to keep in mind what the outcomes are. And you can have any of the risks of surgery, infection, rejection episodes. After transplant, they often are not better than 20/40 or 20/30 because of irregular astigmatism and things like that. So this isn't not like LASIK, and you have to be clear because we are the victims of our own success in ophthalmology, that everyone knows family members, friends that have had LASIK or they've had cataract surgery, and they're 20/20 without glasses. So doctor, if you're offering me surgery, even if you don't tell them this, in their mind, guess what they're expecting? 20/20 without glasses. So you have to do everything you can to educate them and let them know what the realistic expectations are. And so lastly, when you are doing refractive screening, look for a lot of these things we talked about today, just to recap here. Look for skewing of the axis, look for irregular retinoscopy reflex, scissoring. If you do topography, look for inferior to superior difference, if it's more steep one side versus the other. Look for that posterior float, you know, the big red stop sign on the orb scan and Pinta Cam. Ask if they have a family history of keratoconus. The history is really the forgotten art of patient care in many cases. And so ask them, and you'd be surprised how often they say, oh yeah, my brother had a transplant for keratoconus, at which point you say, no refractive surgery for you. And then if they've had a change in refraction, young age is also a risk factor for post-LASIK ectasia. And then there are certain treatment parameters that we utilize to keep ourselves hopefully safer and out of trouble. So thank you for your attention. I hope this was useful, and I appreciate your time today.